Welcome to the Art of Medicine, the program that explores the arts, business, and clinical aspects of the practice of medicine. I'm your host, Dr. Andrew Wilner. Today, I'm pleased to welcome Dr. Evan Glazer. Evan is a colleague at Regional One Health here in Memphis, Tennessee. We pass sometimes in the hospital corridors, but frankly, we're both too busy to stop and chat, so I'm glad to have his attention on the podcast. Dr. Glazer is a practicing surgical oncologist and associate professor of surgery at the University of Tennessee Health Science Center. He also received Memphis Magazine's 2024 Innovator Award, and he'll tell us why. But first, a word from our sponsor, locumstory.com. Locumstory.com is a free, unbiased educational resource about locum tenens. It's not an agency. Locum Story answers your questions on their website, podcasts, webinars, videos, and they even have a Locums 101 crash course. Learn about locums and get insights from real-life physicians, PAs, and NPs at locumstory.com. And now to my guest. Welcome, Dr. Evan Glazer.
Thank you very much. It's my pleasure to be here.
Evan, it's great to see you outside of the hospital. You're so busy, and frankly, I'm pretty busy that when we pass in the halls, can't talk, right? It's like, yeah, hi, and it's like, I don't really want to blow you off, but I got patients to see. So probably this will be our longest conversation for at least the next 12 months. So I'm going to make the most of it.
Absolutely. It sounds great. It is always a pleasure seeing a hallway, but it's almost always it's on the way to rounds, from rounds, or during rounds with our residents and fellows. So always something going on, always someplace to be. And when I'm not in the hallway, I'm usually in the operating room as a surgeon. That's kind of where I belong. And so we're going back and forth.
Right. So I see it looks like you're not working today. Is that right?
That's right. Today is because of the weather outside. I rounded this morning and took a little bit of time off this afternoon to spend with family and worked out well to schedule this conversation.
Right. So, for those of you who don't know where we are, we're in Memphis, Tennessee, and we have a very unusual snowstorm. And it's quite cold outside. And so the powers that be have shut everything down that can be shut down. So it gives us a little bit of a breather. But of course, the patients in the hospital do get what they need. But nobody's going there if they don't have to today, I think.
That's
Um,
right. I ran it for a few minutes this morning, saw the patients. Everyone's doing well, fortunately. And now we just wait for them to heal up.
All right. So you mentioned you are a surgical oncologist. How does that happen? Where does that begin?
So, as a surgical oncologist, I did a fellowship in surgical oncology, and this was after residency in general surgery after medical school. I did my medical school at George Washington University in DC and residency at the University of Arizona in Tucson. I did some fellowships at Moffit Cancer Center and MD Anderson Cancer Center. And a surgical oncologist is really a surgeon who primarily focuses on cancer care and some other types of benign diseases that require a certain level of expertise that we develop in our fellowship. Surgical oncology is actually a relatively new fellowship. It's been going on for many years, but it's now board certified. So my board certification number is number 147. I'm the 147th board certified surgical oncologist in the US. As it turns out, the fellowships existed for many years. There's thousands of surgical oncologists
Hmm.
over the years, but as a boarded specialty, it's relatively new.
So just to put that in perspective, that's 4 years of medical school
That's right.
and 5 years of general surgery
Correct.
and 1 year for the first fellowship.
I actually did 2 years out of a research fellowship in liver and pancreas cancer at MD Anderson, and then 2 years of clinical fellowship at the Moffit Cancer Center in Tampa, Florida.
So that's 4 plus 4 plus 4. So to develop the training to do what you do now, you've spent 12 years preparing. Is that correct?
That's right, after undergrad.
Right. After finishing college, where you probably it wasn't a breeze because you were like me, a pre-med, which isn't
Exactly.
not the most fun. Usually, it's not like American Studies or something where, which they Nothing against American studies, but it usually, at least where I trained, it was not as rigorous as what the pre-medical students had to do. Okay, so now
Yeah,
you're out there, you're a surgical oncologist. Why would a patient come to you?
that's a really good question. In the US, most cancer care is surgery. Most cancer surgery care is provided by general surgeons. And those are surgeons that have 5 years of training in surgery. But there are certain cancers or certain problems that require more expertise that general surgeons don't have that expertise, they're not trained for it. Or what's common is surgeons generally are better at doing what they do a lot of. And surgical oncologists do a lot of cancer surgery, and so I'm more experienced and more training, for example, in pancreas surgery and liver surgery, bile duct surgery, whereas I have less experience in, say, hernias. And so as a surgical oncologist, I don't do a lot of inguinal hernias. Those are groin hernias. Those are done by general surgeons a lot more. Whereas a general surgeon does not do a lot of pancreas surgery. And so he or she, as a general surgeon, would do the inguinal hernia on patients, and I do the pancreas or liver surgery as a surgical oncologist. We generally get better at things we do. And so it's important that we patients see those who have the expertise necessary to take care of them, whether it's cancer or not cancer or anything in between.
Hey, I'll just make a comment that I remember, as a medical student, I studied a lot of diagrams in books. We had books in those days to learn
I've heard about those. I've heard about books.
to learn anatomy and the liver and the pancreas and the bile duct. Wasn't all that straightforward. But I remember going as a third year medical student, I would go to the OR when I was on surgery rotation. My job was to hold the retractor usually in the middle of the night. But when I would sort of peer over the surgeon's shoulder, it was a mess. Nothing was colored, nothing was numbered, everything was moving around. There was blood everywhere, there was fluids, there was sucking. And it was like, this doesn't look anything like the book. And I think that's not generally appreciated, is that a big, and correct me here if I'm wrong, but it seems to me that a big part of the skill of the surgeon is actually just knowing where they are and knowing where the things are that they don't want to touch and where the things are that they do want to touch and what they can reach and what they can't is a big part of what you learn. Is that right?
That's right. And so I think over time, over the last many years, we being the physicians and surgeons have become a lot better at doing the operations and recognizing what are important and how to be better surgeons or better doctors. So as you say, it's not quite always a mess. And you're certainly right that there's no diagrams and no barcodes or numbers in patients. And a lot of time is spent understanding and learning about that anatomy that's there. We have CT scans and MRI scans that are better now than they were 5 years ago and better than 5 years before that. And as these get better, we get more information before the operation to really understand what we expect to see and find, and then how to do the operation. I think your point about knowing what should stay and what should go is a really important concept I try to teach the residents and fellows. That one has to be very sure about what should stay and what should go, and not confuse those because that's when problems arise. I think you also bring up a really good point about, in the textbook, something looks as it does, and then in real life, it looks very different. And as we've had better CT scans and MRIs and PET scans and lots of fancy imaging modalities, we as surgeons get better at doing our job. But we also work with radiologists and other healthcare professionals much more closely than we did 5, 10, 15, 20 years ago to understand and interpret all that data. And probably 5 or 10 years from now, AI will be helping us interpret data even more and help us put pieces together in a way that arguably was unimaginable 10 years ago. And hopefully 20 or 30 years from now, it'll be something I can't even imagine.
Now, oncology is really a technical term, I think, that translates to cancer. Is that right?
Yeah, that's right.
And I'm old enough to remember when I studied in France when I first started medical school. And it was not uncommon for the doctors there not to even tell the patients, not to use that word, cancer, because that just meant they were going to die. And they felt that that was just too overwhelming. So they would sort of skirt around it. I mean, the patients usually figured it out. But I mean, that's how bad it was. So you mentioned there's been improvements in sort of identifying anatomy. I mean, that's good. So that at least you're chopping out, I use that term loosely, delicately removing the parts that need to go. But in terms of prognosis, is cancer still the death sentence that it has the reputation for?
It's not. And it's always difficult to talk about cancer for lots of patients or lots of people, and then talk about cancer for one individual person.
Mm.
Because we can talk about groups of people improving survival, improving treatments, having different types of therapy now, immunotherapy, where we get the immune system to rev up and attack the cancer. But if those treatments don't work for the one person or the one patient we're talking about or the family member we're talking about, it doesn't matter about the other 10,000 patients that have benefited from it if that one patient isn't. I know we're becoming more and more personalized about our understanding of individuals' tumors and how to treat them. And those treatments have made huge leaps and bounds in improving survival. Melanoma of the skin used to be something that once it spread, it was a death sentence. Even I'll say when I was in medical school, so 15 or so years ago, when metastatic melanoma came along, that was often, as you say, a point out, a death sentence. Over the last 15 years, we developed two fantastic therapies, one of which is immunotherapy, which means the immune system is revved up. And now patients with skin melanoma often live a very long time, and some are even cured. I think former President Jimmy Carter is a fantastic example of someone that had what one would consider a miraculous response to immunotherapy 10 years ago is now kind of common. And lots of patients with metastatic melanoma live a very long time, many, many years, uh, with a very high quality of life. Unfortunately, that's not everyone. And so we have to also keep on doing research, keep on pushing things forward to understand tumors better, to develop better therapies, more effective therapies for those patients that don't respond as well as he did to treatments. Pancreas cancer is one of the cancers I deal with a lot, and we've developed better tools to identify it earlier. Earlier stage usually means patients live longer. That's been collaboration with medical oncologists, surgical oncologists like myself, geneticists, radiologists, and all of us put our heads together to develop different techniques and tools to help patients. The medical oncologists use chemotherapy now that wasn't even available 15, 20 years ago. And all those things help patients live longer, although many still die, unfortunately. So our work is not done yet.
All right, let's seg a little bit into a public service announcement that a big part of survival and better outcomes has to do with early diagnosis. Is that correct?
That's right.
And early diagnosis often means routine examinations like regular mammograms or colonoscopies. And this is top of mind now because I just turned the age where I'm due. So I'm waiting for a call from the GI doctor so I can like sit on the toilet for 2 days in preparation for his very unpleasant but potentially life-saving procedure that has to be done every 10 years.
Yeah.
So if you don't do it, you're probably fine, right? Because most people don't get colon cancer. But if you do it and you're one of those people who did get colon cancer, but you didn't know it, then the difference between finding it early and finding it late is the difference between a 20-year survival early or a 1-year survival finding it late. So for me, at least, the choice was to have the routine study seem pretty obvious. Would you like to add to
I
that?
think, yeah, I think it's really an interesting way you put that into perspective. That a colonoscopy, you hope, finds an early cancer with a very long survival, and that's completely correct. I'm gonna put another idea forward there. What was if you did the colonoscopy and you found a pre-cancer lesion, you took it out, and you never developed cancer at all? That sounds even better than finding an early cancer. And that's what really colonoscopy is about. There's lots of different screening modalities we have for colon cancer. Some can find lesions before their cancer, some find earlier stage cancer. And everything you said is 100% true. We certainly want to identify these cancers earlier, get treatment, aggressive treatment to the right patients sooner than later, not jeopardize delays in care, not jeopardize delays in diagnosis. But for colon cancer, which is one of the a very interesting cancer, because we know it becomes cancer after a series of steps. These polyps are these little growths, they're tumors, but they're not cancer tumors. They're generally very small. If we can remove those before they grow into cancer, we've actually prevented a cancer. And you won't become that statistic that we quote about cancer this or cancer that.
Hmm.
And by not being a statistic, you've never had cancer. And so as a cancer surgeon, that's really my goal is to help patients never develop cancer, put myself out of business, so to speak, by doing everything we possibly can to prevent that. Now, often we can't, and often when we see patients, it is they already have that diagnosis. And so certainly we want to identify it as early as possible and get as much treatment in the appropriate patient as possible across to them.
All right, let's push a little further down that path of preventing cancer in the first place, which, might give you more time to spend with your family, leave work
That's right.
early. It wouldn't be a bad thing. But probably be a while before we put you out of business. So, is there anything we can do in terms of prevention?
Yeah, there's a number of things. And so I would start with good exercise, don't smoke, limit alcohol intake, eat healthy, exercise. Those are all things that really decrease inflammation and decrease those signals to the cells that become cancer. Cancer fundamentally is our cells that have a change in them. As we grow older, our cells change. That's normal. Sometimes they change so much that they become uncontrolled, they grow uncontrollably. And when that happens, it usually is called cancer. And then we can have cancer form in different types and different organs and things like that. And those are things that often happen in humans, and we want to minimize that effect or prevent it if at all possible. And so smoking is something that's been going on for a very long, thousands of years, if not longer. But it does cause cancer, increases your risk of cancer. And so we aggressively over the last 50 years have decreased smoking rates, and that's decreased cancer rates, including lung cancer, pancreas cancer, and other cancers. Sun exposure is directly linked to melanoma and other skin cancers. And so, both of my children, very aggressive in the summertime when they're at camp and whatnot, that they wear a lot of sunscreen, myself included. As you can see here, I have a beautiful, smooth head here, not quite as protected as yours from the sun. And so every day I put on sunscreen because I don't want to get skin cancer of my beautiful head here and have to have a surgeon like myself do something there. I'm being a little facetious, but the idea of taking a little action to prevent cancer, I think, is really important. There's other things with nutrition. High protein diet with vegetables are important. I try not to obsess about the next fad diet. I think healthy eating is healthy eating, but fundamentally avoiding things that look, I don't want to say too good, but generally if it looks good, careful how much you eat. I think it's unrealistic to say don't eat anything. A little chocolate is quite all right. I still drink coffee, but I do think that being able to live a good, enjoyable life is important for a lot of people. That it means eating a lot of food. It doesn't mean we always have to eat every bit of fat and grease and dessert and all this stuff that lots of people do.
Right. The corollary to that is if you don't like it, say like steamed broccoli, then you can eat as much of it as you want.
Absolutely right. Steve Barkley. Well, I think there's also a trick to sort of find out what you like. So, for example, my family and I especially really like spinach. And so we'll try to eat more spinach. We also found that grilling is something I enjoy grilling outside. Like we mentioned, it's snowing right now. So, not today, but during springtime and summer, we grill a lot. And generally, you can be a little bit healthier where it's not fried, it's grilled. And so, little things can be done in your home to make things just a little bit healthier. I think that matters.
All right. So let's suppose you have, I don't know, a 60-year-old guy. He's got a lump on his neck. He goes to the doctor. I don't know. Let's do a CAT scan. They do the CAT scan. There's a lump in the neck. I don't know. Somebody's going to have to biopsy it somewhere, maybe ENT because it's the neck. Neck's kind of a no man's land, right? It could be kind of anybody who gets to biopsy.
Shared responsibility. So there are general surgeons that go there. ENT certainly that's neighborhood. Some surgical oncologists operating the neck. It depends on who's in your neighborhood, so to speak.
All right. Well, then the bad news is it's cancer. So should that patient just go to the surgeon or whoever did the biopsy and say, okay, take it out? Or should they go to a cancer, center? How do they know?
I think it's really important that really what you're asking, what the patients ask is, how do I know that I'm getting the right treatment at the right time for the right thing? And that really is about multidisciplinary care. More and more cancers, almost all cancers, patients with almost any cancer benefit from having that multidisciplinary care. And so you want to see a medical oncologist who's a cancer doctor who does care with chemotherapy. And you want to see a surgeon, whether it's a general surgeon or a surgical oncologist or an ENT, depends on exactly where it is, but someone who has experience and has taken care of patients like yourself multiple times before. And you want them to talk and get together. And to have that collaboration usually requires a cancer center type setup or close collaboration. And both are available in Memphis and both are fantastic. But those are the questions you want to ask is, and I have to be a little careful how I say this, all patients are special, but you don't want to be too special. You don't want to be too unique, and your care team never seen or heard of anything like this before. And that really is what expertise comes down to. And I think that's important. I think having a team that's collaborates and works together and communicates is really important, and that they get together in the same room, or in this case now it's virtual. So I'm involved in multidisciplinary tumor boards or conferences every week, and it's made up of surgical oncologists and medical oncologists and radiation oncologists and radiologists and geneticists and lots of other healthcare providers where we discuss patients and their cancers and discuss what the treatment is. There's also something called the National Comprehensive Cancer Network. And this is an organization that the University of Tennessee, where I'm on faculty, belongs to. And there's about 33 or 34 institutions in the country that get together at least once a year, often more frequently, to discuss the best available evidence and data that's in hand, and publishes essentially guidelines that different insurance companies use and patients use and doctors use to help guide therapy. These aren't meant to replace that doctor-patient relationship, but how to generally approach each of these cancers. And this is a fantastic resource. It's free. And obviously, I enjoy being part of this. I enjoy being on the cutting edge of care and learning about this with my colleagues. And those are things that you want in a healthcare provider, someone who's up to date on the resources, up to date on the information, up to date on the clinical trials, can provide that expertise of all types: chemotherapy, surgery, radiation, anything in between.
All right. So I think we've established that healthy lifestyle, regular checkups, and cancer screenings. And if it turns out that is something you have, you want to make sure that you're getting state-of-the-art care from your physician, or ask your physician to refer you to a center where there's a whole bunch of people that do this kind of thing every day. Does that sound right?
That's right.
All right. Well, Evan, this has been a informative conversation for me. Is there anything you'd like to add?
Like I say, thank you very much for the invitation. It's great to see you again and chat with you for more than 5 seconds in the hallway. And thanks for the opportunity to share some of this information with the world. And I think this is a great venue to sort of talk about the art of medicine, the art of surgery, perhaps, art of surgical oncology.
Dr. Evan Glazer, thanks for joining me on the Art of Medicine.
Thank you.
And now a final thanks to our sponsor, locumstory.com. Locumstory.com is a free, unbiased educational resource about locum tenens. It's not an agency. Locum Story exists to answer your questions about the how-tos of locums on their website, podcast, webinars, and videos. They even have a Locums 101 crash course. At locumstory.com, you can discover if locum tenens make sense for you and your career goals. What makes locumstory.com unique is that it's a peer-to-peer platform with real physicians sharing their experiences and stories, both the good and bad, about working locum tenens. Hence the name, Locum Story. Locumstory.com is a self-service tool that you can explore at your own pace with no pressure or obligation. It's completely free. Thanks again to locumstory.com for sponsoring this episode of The Art of Medicine. I'm Dr. Andrew Wilner. See you next time. This program is hosted, edited, and produced by Andrew Wilner, MD, FACP, FAAN. Guests receive no financial compensation for their appearance on the Art of Medicine. Andrew Wilner, MD, is Associate Professor of Neurology at the University of Tennessee Health Science Center, Memphis, Tennessee. Views, thoughts, and opinions expressed on this program belong solely to Dr. Wilner and his guests and not necessarily to their employers, organizations, or other group or individual. While this program intends to be informative, it is meant for entertainment purposes only. The Art of Medicine does not offer professional financial, legal, or medical advice. Dr. Wilner and his guests assume no responsibility or liability for any damages, financial or otherwise, that arise in connection with consuming this program's content. Thanks for watching. For more episodes of The Art of Medicine, please subscribe. www.andrewwilner.com